Okay, that's great. So, and I'm getting a virtual meeting disclaimer that we're recording. Good morning. I'm Dr. Tracy Liu from the Kaiser Permanente Division of Research in Northern California. I'm also the chair of this committee on addressing evidence gaps in clinical prevention. As the chair of this study and of this meeting, I'd like to welcome everyone. The task being undertaken by this committee of the National Academies of Sciences, Engineering, and Medicine is to assist the National Institutes of Health and the Agency for Healthcare Research and Quality, the sponsors of this study, in filling evidence gaps within the recommendations of the U.S. Preventive Services Task Force. The formal statement of task can be found on the project website, and we'll look at it in a minute. I want to note that this is an open on-the-record session. We'll post the audio files and the PowerPoint slides on the project website in a few days. I'd like to remind everyone that this is an information gathering session. That is, the committee is in the process of assembling materials that it'll examine and discuss in the course of making its findings, conclusions, and recommendations. Therefore, I ask everyone here today to be extremely mindful of the fact that the committee has made no conclusions, should not, and it would be a mistake for anyone to leave here today thinking otherwise. Comments made by individuals, including members of this committee, should not be interpreted as positions of the committee or of the academies. In addition, committee members typically ask probing questions in these information gathering sessions that may not be indicative of their personal views. The committee will deliberate thoroughly before writing its draft report. Moreover, once the draft report is written, it must go through a rigorous review by experts who are anonymous to the committee, and the committee must then respond to this review with appropriate revisions that adequately satisfy the Academy's Report Review Committee and the National Academies of Sciences President before it's considered an official Academy's report. Before turning the meeting over to our invited guests, I'd like to invite the committee to very briefly introduce themselves. And we'll go in alphabetical order by last name, starting with Kathy Bradley. Kathy.
Good morning, everyone. I'm Kathy Bradley. I'm the Associate Dean for Research, Colorado School of Public Health, and the Deputy Director of the University of Colorado Cancer Center.
Great. Yan Huang.
I'm Yan Huang, and I'm from NYU School of Medicine and Department of Population Health, and I'm an Associate Professor. Thank you.
Thank you, Yan. Preeti Kocher.
Hi, I'm Preeti Kocher. I'm a technical information specialist at the National Library of Medicine. I work on vocabularies and especially making things fair, findable, accessible, interoperable, and reusable.
Ann Kurth.
Everyone, I'm Ann Kurth, Dean of the Yale School of Nursing and Professor at the Yale School of Public Health.
Thanks, Ann. Tianjing Li.
Good morning, Tianjing Li, Associate Professor in the Department of Ophthalmology at University of Colorado Anschutz Medical Campus, epidemiologist and clinical trialist.
Terrific. Venkat Narayan.
Yeah, I'm Venkat Narayan. I'm in the faculty at Emory University, and I run the Emory Global Diabetes Research Center.
Great. Wanda Nicholson.
Good morning. I'm not sure why my picture's not showing up. I'll have to do a little adjustment, but I'm Wanda Nicholson. I'm Professor of Obstetrics and Gynecology at UNC Chapel Hill.
Great. Thank you, Wanda. Do we have Elizabeth Feely? I haven't seen Elizabeth come in.
I believe she's going to be joining us a little bit later, Tracy. She had clinic this morning.
Got it. Thank you. Nico Pronk.
Good morning, Nico Pronk. I'm president of the Health Partners Institute and chief science officer for Health Partners Health System in Minneapolis.
Great. Bob Wallace.
Good morning. I'm professor emeritus of epidemiology and internal medicine at the University of Iowa, and I was on the task force with Hal Sox and David Atkins. I think I met you there first also.
Good. And actually, I'm going to turn to our National Academies staff. So I'm looking first to Kathleen Stratton.
Hi, my name is Kathleen Stratton. I'm a senior study director in the Board on Population Health at the Academies.
Alexis.
Hi, I'm Alexis Wodowitz. I am staffing this project as an associate program officer.
And Asia Coltrane.
Hi, good morning, everyone. I'm Asia Coltrane. I'm the senior program assistant on this project.
Okay. That's great. Thank you so much. For our morning session, our first speaker, Dr. Amy Lansky, will provide perspectives from the Centers for Disease Control and Prevention, which sponsors the Community Preventive Services Task Force. Our panelists, Mike Lauer, Hal Sachs, and David Atkins, will discuss how sponsors, including NIH, PCORI, and the VA, identify and prioritize evidence gaps in clinical prevention. I'd like to start by inviting our first session speakers to introduce themselves the way that our committee members have done. And then I'll start by offering some framing comments, and then we'll go to presentations. After our presentations for the first session, I'll moderate a discussion between our speakers and then open the meeting up first for comments and questions from the National Academies committee members. We'll also invite members of the task force to join in the discussion, and I'll let our panelists introduce themselves at this point. So Dr. Amy Lansky.
Hi, good morning. I'm Amy Lansky, and I am the director of the Community Guide Office, which is the office that supports the Community Preventive Services Task Force. Thank you, Amy.
Mike Lauer.
Hi, I'm Mike Lauer. I'm the NIH Deputy Director for Extramural Research.
Thanks, Mike. Hal Sachs.
Hi, I'm Hal Sachs. I'm an internist, used to be with a task force, and am now Director of Peer Review for PCORI.
Great. And David Atkins.
Hi, I'm David Atkins. I'm Director of Health Services Research at the VA. And I started my government career as a science advisor to the task force with Bob Wallace and Hal in an era when we didn't all have email addresses. That's how far back it goes.
It was many years ago. This is great. Let me take just a couple of minutes to set the stage and orient everyone to the task that is before the committee and for us this morning. So I'm going to, I'd like to share my screen, but I actually see that the host has disabled participant screen sharing. So actually, Alexis, why don't you go ahead and go to the slide, first slide in my presentation. I'll ask you to advance the slides. Okay, great, you've got it. So I want to start with two slides on our statement of task, just to reiterate for everyone what we are, what we're out to do this morning and for the committee's work. So first, we are trying to produce a report that will outline how research gaps are described in the current U.S. Preventive Services Task Force portfolio. The second task is an interesting one. It is to propose a taxonomy for describing research gaps and to apply it to a sample of existing U.S. Preventive Services Task Force evidence gaps, including, importantly, I statements, which are statements of insufficient evidence. Our sponsors, NIH and HRQ, have alerted us to the idea that this taxonomy, you know, in part, there are some existing taxonomies which do not fully cover the needs for the task force to be communicating with research sponsors about the studies that would best help move from I statements to letter grade statements. So this is an interesting part of our task. Next slide, Alexis. So we also will be discussing the types of research studies that are needed to inform the different types of evidence gaps. And finally, the committee is meant to propose ways that prevention research funders, including NIH, although not limited to NIH, and recommendation statement developers, including the U.S. Preventive Services Task Force, can enhance their partnership to accelerate research to close important gaps in prevention. Next slide, Alexis. If you like visuals, I just want to show you how we are framing some of the concepts in in our thinking at this point. So, and this is my own, actually, the committee has not worked on or discussed this, but I think that it's helpful in terms of our thinking about where some of our focus needs to be. So if you think about a task force statement where there is insufficient evidence, what really needs to happen is that it needs to move to a letter grade statement, usually an A or a B, sometimes a C or a D, meaning that this service either does not have benefits that outweigh its harms or that it shouldn't be done. But an A or a B would mean that it could then go into implementation and dissemination. There are equity needs implied in many of the statements, either A or B recommendations or even I statements. When a statement has asserted that there is sufficient evidence for benefits to outweigh the harms of a particular preventive service, then the implementers of that service need to think about a number of issues that the current chair, Alex Christ, has pointed out, include service intervals, service intensity, modifications to that service, and whether every component of the service is required for it to be effective. There are also a number of what we think of as dissemination issues, such as, is the service effective in a range of settings? How can we give everyone access to that service? How can it be delivered consistently across a variety of different types of systems? And these also touch on equity needs. So, so that's a framing of some of the workflow and the concepts in what I think Alex would call the life cycle of evidence, that it needs to address all of these different domains. Next slide, Alexis. So when we think about research needs, the committee thinks broadly about research needs as encompassing research that could inform any of the arrows contained in this box. But I think that our sponsors have made clear to us that they want us to think particularly and with some priority about a particular type of research need. Next slide, Alexis. So when we say evidence gaps, we are talking about a particular type of research need that would help the committee, in this case, the U.S. Preventive Services Task Force, move from an I statement of insufficient evidence in an area to an A or a B recommendation or a C or D recommendation, meaning that there is now sufficient evidence to say whether the benefits of a particular preventive service or intervention outweigh the harms. So it would move from an area where the research is really not definitive to, if we address evidence gaps, to a task force statement. And this type of nomenclature is not really uniformly used, but I like it because it helps us clarify that although we are quite interested in the large body of research needs, our sponsors want us to focus particularly on evidence gaps. And we'd actually like to address both levels of focus in the work that this committee is doing. So, so actually, Alexis, why don't you show the next slide in this set? And we will go now to our first set of speakers. So let's turn to Amy Lansky. Thank you so much for being with us, Amy. We're very interested to hear the perspective from CDC.
Well, thank you very much for the opportunity to participate in the panel today. And I don't have slides, but as I am representing the agency, I do need to note that the CDC disclaimer applies to my remarks, just so we have that on record. And I am focusing my remarks from the perspective of the community guide and the Community Preventive Services Task Force. And the community guide is actually the repository of the Community Preventive Services Task Force findings, as well as related resources and information. And so sometimes I'm talking about the task force, sometimes about the guide, which is the place where we put things. And so I'll start with some of the basics by describing our terminology for evidence gaps and insufficient evidence findings. So for the community guide, an evidence gaps refers to a lack of evidence that limits the task force ability to answer questions about a particular intervention approach in a given systematic review. And as a routine part of the community guide method for conducting these reviews, after they determine the effectiveness of an intervention, the team will highlight evidence gaps that may have emerged during the review process. And these gaps may be identified in the literature by the team or from our applicability assessments. And common evidence gap questions are, will the intervention work for everyone, or how might it affect populations differently? Will the intervention work everywhere, or is it more effective in certain settings? And are some intervention components more important than others? And does it matter who delivers the intervention? So these questions and the identified gaps may derive from information that is missing, that's not well documented or described in the included studies, or perhaps refer to the quality of the study design or execution. And often evidence gaps are identified regarding the measurement of outcomes or aspects of the intervention, such as ease or level of access, or types of services provided in conjunction with the intervention, and other issues such as whether there's a dose-response relationship between the intervention and the outcomes. And evidence gaps can come from issues raised by task force members based on their expertise. So while every community guide review includes evidence gaps, they can be highlighted or prioritized in various ways. Sometimes evidence gaps are actually included in the task force recommendation statement. And a recent example of this comes from the task force finding about tenant-based housing voucher programs. And in the recommendation statement, the task force noted that outcomes for adolescents varied by gender. And for females, there were better health outcomes, while for male youth of the same age, there were worse physical and mental health outcomes. And they noted that additional research is needed to better understand and address challenges faced by adolescent males. So that type of language about an evidence gap appears right up top with the recommendation statement. Evidence gaps are also a required component of the Community Preventive Services Task Force annual report to Congress. And this is a report that's distributed to members of Congress and then also made available on the Community Guide website. And the most recent 2018-2019 report that's available included specific evidence gaps from individual reviews, as well as common evidence gaps across interventions. And these are able to highlight, again, sort of what is unique to some interventions and what is common across others. And that's a way to highlight some of those evidence gaps. The second issue pertinent to the discussion is about how the Community Preventive Services Task Force and the Community Guide methods address insufficient evidence findings. And the task force will issue a finding of insufficient evidence, which is similar to the USPSTF I statement, when the available studies do not provide sufficient evidence to determine if the intervention is or is not effective. It does not mean that the intervention does not work, and that's a common misconception. It means that additional research is needed to determine whether or not the intervention is effective. And insufficient evidence may pertain to a small body of evidence that is not enough to support a recommendation based on the guidelines that the task force has set up for their recommendations. Or it may refer to a body of evidence that does not have consistent findings, meaning that the included studies do not consistently demonstrate an effect in the direction of the intervention. Findings of insufficient evidence are searchable on the Community Guide website from our list of all findings. So you can specify insufficient evidence on our drop-down menu of finding types, or we also have printer-friendly tables that list the IE findings by topic. In the annual report to Congress that I mentioned, we also list all of the findings for the reporting period and would include IE findings available to researchers and funders to encourage them to use these as the basis for their own research or funding proposals. And this is an area in which we've collaborated with the NIH Office of Disease Prevention. Funders of recent systematic reviews and task force recommendations include government agencies, nonprofits, and industry. And a recent study on sources of support for Community Preventive Services Task Force recommendations found that government agencies supported more than half of the studies, primarily NIH, followed by CDC. And you have this paper in your background materials for this meeting. We're currently updating fact sheets for the Community Guide website that identify ways researchers and funders can use the insufficient evidence findings to enhance their proposals or their funding announcements. And this includes designing studies to address evidence gaps or developing funding proposals that would increase or enhance the evidence base for a particular intervention. We also point out that information posted on the Community Guide website about a particular review that has an insufficient evidence finding can be used to help write sections of the proposals, like the background, the rationale, or the justification. So it can give both funders and researchers a little bit of a leg up in writing these background type of sections. The dissemination of the fact sheets when they're completed will focus primarily on funders from NIH institutes, centers, and offices, as well as CDC centers, institutes, and offices as funders, and researchers who are NIH or CDC funded recipients. I also wanted to note that in addition to researchers addressing evidence gaps or IE findings, we also have programmatic examples of how public health organizations might implement and evaluate programs that had an IE or insufficient evidence finding. So we have, for example, a cancer screening program in South Carolina, which determined that even though there was insufficient evidence, they wanted to go ahead and implement and evaluate that program, thereby contributing to the growing evidence base. And I will say this type of real-world program evaluation is a staple of Community Guide methods and the evidence reviews for the Community Preventive Services Task Force. In just wrapping up, I would note that the challenges that the Community Preventive Services Task Force faces in terms of communicating about evidence gaps and insufficient evidence findings and working to get them addressed are very similar to those of USPSTF. In our collaborations, both across the task forces and between AHRQ and CDC as the supporting agencies, I think we really can identify ways to work together to raise awareness about the gaps among researchers and funders so that they know more about CPSTF insufficient evidence findings and USPSTF I statements as critical sources of information to guide their work. So thank you, and I look forward to hearing from the other panel members and the discussion today.
Great. Thank you so much, Amy. That was a terrific overview and set the stage very nicely. We're going to take questions all together at the end of the four speakers that we have. So why don't we look to the second panel on funders and go to Mike Lauer.
Great, Tracy, thank you very much. And thank you for inviting me to be here today. I thought I'd start with a real quick story. This was back in 2007 or 2008. I'm sitting at a conference and we're talking about CT angiography. I was in the audience. One of the speakers got up and he said, "I'm sick and tired of hearing about randomized trials and why we need to have randomized trials." I see Dr. Lauer sitting out there in the audience, and I don't exactly see him writing a checkbook, or writing in a checkbook. And so the point was, we all knew that this was high priority. The question was, how were we going to pay for it? Well, the following year, we got lucky, and Congress passed a large bill which gave a lot of additional money to NIH. And so that enabled us to fund the trial. The trial was called Promise. It enrolled 10,000 patients. It was a nice study and eventually led to a result which many of us think are clinically actionable. But I think the story is an important one because it points out you may know what your priorities are, but ultimately you're going to have to pay for it. And some of these are going to be very expensive. Go to the next slide, please. So this came out last week, very exciting, updated recommendations regarding screening for lung cancer. And if we go to the next slide, we'll all remember that some of this is based on a large trial that was funded by the National Cancer Institute, the National Lung Cancer Screening Trial. We go to the next slide. This was a huge trial. It involved 53,000 smokers. They were randomized to screening or no screening. The trial found that there was a reduction in lung cancer deaths, and there was also a reduction in all-cause deaths. This trial cost a huge amount of money, many, many tens of millions of dollars, if not more than that. If we go to the next slide, this is a different disease, but an important prevention question. This involves patients. This is a trial called SPRINT, and I was involved with this one at the National Heart, Lung, and Blood Institute. This trial asked the question as to whether or not aggressive blood pressure reduction could prevent cardiovascular events and other types of problems in patients with systolic blood pressure, hypertension. And the trial involved about 10,000, not quite 10,000 patients. And if we go to the next slide, the results were quite impressive. There was a substantial reduction in the number of primary events. There was also a reduction in all-cause mortality. So this trial also involved a large number of events, a large number of patients. This trial cost over $150 million. This was a lot of money to get this trial to go. We go to the next slide. And now we come to a very urgent prevention question. This is one that has been, of course, of great interest to us over the past year. By the way, today is the 1-year anniversary of when we all went on telework at NIH. It's a very significant date. And I think at that time, when we were thinking about vaccines, we were really quite concerned that that was going to be light years away. Well, this trial, the Moderna trial, actually was the results were announced in December. This was a 30,000 person trial. And go to the next slide. And the results were really quite amazing. There were 228 events. By events, we meant symptomatic COVID infection. And there was a 95% efficacy of this trial. This trial also cost a huge amount of money. Now, an important point about the trial is that this was not done alone. NIH did not do this one alone. This was in partnership with a company. It was also in partnership with other agencies in government. And there were also monies that were made available to enable this trial because it was clearly identified as being a high priority. So one slide that I didn't put on is a study that literally just came out. I'm sure Tracy is quite familiar with this one. And that is, it was in, I think, last week's New England Journal. The lead article was a screening trial. It was a pragmatic screening trial of 2 different strategies for gestational diabetes. 24,000 patients. And what they found was that the 2 different strategies did not lead to major differences in gestational and neonatal outcomes. Now, what was really cool about that trial was done at Kaiser. It was funded by an R01, and it cost less than $5 million. And I've actually confirmed that. I checked in with Diana Bianchi before this meeting. Is that real? Is that for real? And the answer was yes. And part of it was that the trial had a pragmatic design, and part of it was that they leveraged Kaiser. Kaiser is a healthcare system, and they were able to leverage it in order to be able to get that study done. So my final thoughts, if we go to the next slide, is that with that exception that I just met, well, actually, that one is not an exception. So one is that in order to be able to answer a prevention question, you almost invariably need very large sample sizes. That we all know, because by the very nature of prevention, we're looking at people who are healthy or relatively healthy. You need a large number of events in order to be able to come up with a robust result. In general, these trials require large teams. This is not R01 material. This is not your professor who's trying to get tenure. This is a totally different kind of structure. Sometimes it involves, for us, it involves contracts and existing networks or large-scale cooperative agreements. With rare exceptions, the costs are really high. And by really high, I mean tens of millions of dollars, sometimes well over $100 million, and therefore the opportunity costs are very high. The attention is high. We, in the case of the lung cancer trial, we were accused of doing something that was unethical. In the case of the systolic hypertension trial, I was personally told by a number of people that it was an enormous waste of money and was not going to show anything useful. And another way that we often hear about this at a funding agency like NIH is how many R01s are going to be lost, or how many points down the pay line are we going to go because you're funding this gargantuan study. And then finally, as a general rule of thumb, these studies take a long time to do. So the time from idea to germination, application, protocol development, can be many, many years. Now, the mRNA COVID vaccine is an example of how when the priorities are really strong, of course, COVID is also a short-term disease, which is another issue. But nonetheless, one can get things done very, very quickly if the stars are all lined up and the money is there and the priorities are very clearly articulated. So anyway, I hope you found that interesting, and I look forward to the discussion.
Great. Thank you so much, Mike. We'll turn next to Hal Fox. And Hal, you might need to take yourself off mute.
Yeah, good. So everybody knows about the NIH and the VA, but not so many knows about PCORI. So I'm going to give a brief introduction. We were founded basically 11 years ago. And recently been reauthorized for another 10 years. During the first 10 years, we've given away $2.8 billion as a B, and 1,700 research projects. And I was interested to find that about 30% of those had prevention in the title. So it's not as if PCORI, with its relatively small amount of money to give away, isn't paying attention to prevention. Next, please. Next slide, please. So this slide basically defines what comparative clinical effectiveness research is. And although we don't fund cost effectiveness research, our reauthorization now allows us to fund the collection of costs of an intervention. So we're making some steps. Next, please. We fund patient-centered outcomes research, and that's going to be a recurring theme during my brief talk. Next, please. So we engage our fellow funders. ARC and NIH have been frequently informing us about what they're doing, or in some cases collaborating on a study. We listen to the task force and other guideline developers about their evidence needs, and in many cases fund systematic reviews to address those. And finally, we pay a lot of attention to patients and other stakeholders when we decide what we're going to study and some of the details of the study, like the outcomes. And sometimes this really works. We asked guideline developing organizations to nominate topics that we would fund on systematic reviews and got a great response. Next, please. So I'm going to do something quite different than Mike. I'm going to focus on the fourth of the elements of your charge, propose ways for prevention researchers and recommendations statement developers to enhance their partnerships and to excel research to close important gaps. Now, my take is that to enhance partnerships is going to require a good understanding of how a partner actually makes decisions. And so the rest of my talk is going to address how PCORI sets priorities and develops its research agenda. Funding decisions are easier when the topic is high priority, so it's a good idea for an interested stakeholder to succeed in making their topic of interest to us. Next, please. So this is our funding. Most of it is for research. The so-called broad funding line are investigator initiated. They decide on the research question, but most of the money goes for these pragmatic clinical studies and targeted studies. And for these, PCORI, with input from patients and stakeholders and other funders, specifies the research question. So how we specify a research question ought to be of a great interest to anybody who would like research done on their topic. Next, please. So first, we're going to talk about priority setting for a funder, and then a little bit about research agenda setting. Next, please. So PCORI's enabling legislation back in the early 2000s charged it with establishing national priorities and a research agenda. It's right there in the language of the law. And it was to guide it in funding comparative CER and presumably to make it feel accountable when it made funding decisions to stick with priorities and the agenda that they had set. And the PCORI Board of Governors approved our national priorities after a formal public comment period, and here they are, the 5 bullets. They're quite broad. They specify categories of research rather than research topics, and they've really served us very well during the past 10 years. Next, please. Now we're newly reauthorized and we are refreshing our national priorities and research agenda during this year. And under the auspices of the Board of Governors, we're making sure that we have good engagement with stakeholders, which include those listed here. We are doing a survey of the national health and healthcare priorities of 49 diverse organizations over the broad US, including NAM, CMS, NIH, and many regional healthcare systems. And we are having formal discussions with health and healthcare leaders, some under the auspices of the national academies, and actually are going on right now. And finally, there'll be a formal public comment period on our draft. And then we'll go on to the specifics of our research agenda. Next, please. So our reauthorization legislation put us under some obligation to pay attention to certain areas in our funding strategy, such as continued attention to maternal mortality and to intellectual and developmental disabilities. And we're working hard already to up our game on that. And in addition, we were told that we needed to balance short and long-term priorities, some 6-month studies to go with some that would last 5 years, and to be responsive to our nation's priorities, medical evidence, and healthcare treatments. And we've done a lot, put a lot of effort into COVID-19 and continued on eliminating disparities. Next, please. So what are our priority setting criteria? They're listed here, and systematic reviews play a big role in them, and we require citation of a systematic review in any viable application for research funding. Next, please. So here's a nice case in point of how PCORI works with a fellow funder. Recently, we've been put on to the topic of urinary incontinence by multiple stakeholder organizations. We identified an existing but somewhat outdated systematic review, and collaborating with ARC, we funded an update of this review. And now we're talking about a funding announcement to address remaining evidence gaps. So next slide, in conclusion, relationships matter for funders, especially relationships with end users. Systematic reviews are perhaps the major, but not necessarily the only source of evidence gaps. You also identify evidence gaps by talking to patients and clinicians and others. And finally, research questions should reflect user-level considerations and input. Thank you very much.
Great. Thank you so much, Hal. And last but not least in this session, David.
Thanks. Can people hear me okay?
Yes.
Great. Next slide. So I get to go last because I think I'm in a unique position at the VA in that we are both a funder and consumer of research. And I think we're very proud in the VA that we, as an integrated health system, do a good job at delivering A and B recommended services. We've been recognized for our colon cancer screening. We have universal alcohol screening, high rates of smoking cessation, et cetera. At the same time, as a big organization, we recognize that delivering services at scale can be a challenge, and we're acutely aware of the burden on primary care teams these days. So we are not looking for more services of low value. So I think we strike a good balance between committing ourselves to the things that are a proven benefit and not making an effort to deliver things that might work but aren't proven. The other advantage we have is, as a system with 2 decades of electronic health record data on 9 million veterans, I do think there are opportunities to use that to address the problems Mike commented about, the problems of prospective randomized trials. And I think there are opportunities to think about where the evidence gap is something that could be filled by a large population-based prospective study, either to look at the health consequences of undiagnosed disease, or to look at sort of natural experiments where there are variations in practice. And then lastly, where we think it's worthwhile, though, we do invest in these difficult, expensive trials that Mike pointed out. To take one trial that is currently underway, we do a very good job at colon cancer screening, but we have trouble providing access to colonoscopy. And so we recognize the value of really seeing whether colonoscopy actually was any better than newer high sensitivity stool testing. So we've enrolled 50,000 veterans. By 2017, we'll be following them for 10 years for incidence of cancer and mortality from colon cancer. Because this is incredibly important issue for the VA to know whether we really should be investing our resources to try to provide colonoscopy or whether we can do it as well with a cheaper, equally effective test. Similarly, we funded the Pivot trial, which was while not a screening trial, was sort of critical to look at the value of prostate cancer screening. We have more prostate cancer patients than any other health system, to look at whether detecting early cancer and treating it with surgery provided a benefit. Next slide. So actually, this was an interesting opportunity because it forced me to go back online and see how far the task force has come since I last worked with them, and to see the progress they've made, and to see how many recommendations there really were. And due to the great website at the task force, I could easily sort how many recommendations there were, and I found 46 different recommendations, mostly in this screening area, some in counseling and preventive medications. But of interest, that almost half of them reflected recommendations where there was an accompanying B recommendation or D recommendation for some other component of the service. Sometimes that was reflecting a subpopulation. Sometimes it was reflecting a variation on the service. So for example, statins were recommended for primary prevention for high-risk patients in an age range 45 to 74, but because the trials hadn't really enrolled people over 75, and there were some concerns about potential risks in patients who had survived without heart disease, they gave that an I recommendation. Similarly, good evidence for screening women for gonorrhea and chlamydia to prevent PID and infertility, screening sexually active men where prevalence is just as much of a problem. There was uncertainty as to whether that was as effective a strategy. One thing that I had to go back to my bookshelf to remind myself is that we didn't always have I recommendations. I think when Bob and Hal and I started with the second task force, we had A through E, and when the third task force came up, we recognized that some of our C recommendations were a reflection of small benefit and some were a reflection of no evidence. And so that's where the I recommendation came out. And I think it was it was a useful development and evolution because it was a call to researchers for an area where we thought research could make a difference. Next slide. So the problem is there are many ways to I recommendation, and I'm sort of reminded of Tolstoy, you know, all unhappy families are unhappy in their own way. You know, our A recommendations tend to follow a similar route, but you can get to an I recommendation, and it's our unhappiest recommendation because our researchers are mad. What do you mean there's no research? I've been doing this research for 10 years. No one likes to give it an I recommendation, but the ways you get to an I are varied, and this may give us some hint about the value of a taxonomy and the ability to tackle some of these gaps without the prospective randomized trials. Sometimes there were just questions about the effectiveness of the interventions. We knew there was a problem, we knew we could detect it, but what we did with that, our interventions were really limited. This relies to cognitive impairment in seniors, suicide screening. We don't have great interventions proven to reduce suicide. Sometimes it reflects the population. We know tobacco cessation works in adults, not so effective in teenagers whose views of risk and everything are changing. Sometimes the problem is not that you can find it and treat it, but the question is, how much value is it in finding it a little bit earlier in patients that are going to eventually present? And this relates to vision screening and hearing screening, things that are not fatal. We know it often goes undetected, but should we be systematically screening to catch people a little bit earlier before their deficits are causing them to seek care? Sometimes, and I would say this is actually the minority of the ones I looked at, there actually is evidence, but the evidence is somewhat conflicting. Often, and these reflect these cases where there's a B recommendation and an I recommendation. It's that The evidence is focused on high-risk groups, such as AAA screening in men or osteoporosis screening in women. And then there's a question about applying that evidence to a lower risk group. Sometimes it's a question of and often it's sort of a question of the balance of benefits and harms. When you get into a group that's substantially at lower risk, does the intervention actually work as well, and is it going to provide benefits greater than harms? Sometimes the data have largely relied on subclinical endpoints because the disease is very slowly progressive, something like glaucoma. We know we can detect glaucoma, we know we can treat it. The endpoints have largely been on screen-detected visual deficits as opposed to something that might be called patient-centered outcome. Similarly, we know osteoporosis can prevent subclinical fractures in men, but we don't have long enough data to show that it presents clinical fractures. And what is the relevance of some subclinical vertebral fractures? And then lastly, there's the concern that you can, if you cast your net widely enough, you'll pull in some fish, but you'll also pull in a lot of things that you didn't necessarily want to catch, and the value of treating isn't as clear-cut. And that relates to something like thyroid dysfunction. Next slide, and I think I'm wrapping up here. So how do we think about our priority gaps as a funder? So I think we obviously are interested in prevention, and we'd be interested in thinking about where we are a good place to tackle these gaps. And the first is obviously, is this an important problem for our population? We have a growing population of women, but we are still a large majority of older men. That's going to change as the Vietnam-era veterans age out. We are interested in whether there's an intervention we can deliver at scale if the prevention is effective, and we're quite interested in what the downstream consequences are and whether they're manageable. We have started to stand up lung cancer screening in the VA, reflecting the strong evidence and the high risk of our population. It's not a trivial endeavor to deal with all the positive screening tests, the diagnostic CTs, the small nodules, et cetera. I think we're quite interested in, where do we provide some competitive advantage for studying this issue? We are a small funder relative to NIH, but where we can answer a question better than anybody else, I think we're eager to walk into that space. And then lastly, thinking about the EHR data as a potential source of new data. We do know that there's variation. We're a large system with 1,000 sites of care. Our clinicians do not all practice the same way. That does allow opportunities to look at variation. If you see a variation in a clinical service, do you actually see a difference in clinical outcomes? That can provide some, albeit lower quality evidence, some useful evidence. Sometimes, as I pointed out, the real question is, well, what really is the clinical significance of preventing progression of disease? And prospective cohort studies using EHR can provide ways to fill in that data. And then lastly, sometimes we have a natural experiment because we've suddenly adopted a new service. One could look at our lung cancer screening as an example. We could see what the impact of introducing lung cancer screening in the VA has had on our lung cancer mortality. We are doing suicide prevention at scale, trying to identify our high-risk patients with suicide. That also provides a natural experiment to see whether as a population we're seeing an effect. Obviously, these all are confounded by the fact that there may be other temporal changes going on that may complicate a before-after experiment. So I think that's, next slide. I think maybe I have one last slide in conclusion. So random observations. I think I agree with Mike that a lot of these eyes are not going to be addressed with definitive screening trials because they're expensive and the low-hanging fruit has been harvested. I would say that there's some eyes that probably, if we considered provider burden and the likelihood of real benefit, we could probably say not all eyes can grow up to be A's or B's, and maybe there's some eyes we should just say, look, the evidence isn't perfect, but this is not a promising area. And then lastly, I hope that through some combination of either targeted high-risk trials or better natural history EHR data, we can close the gap in that. And I will close there. Thanks.
Okay. So thank you so much to Amy, Mike, Hal, and David for a terrific set of presentations. In a minute, I'm going to open up to committee comments and questions for our speakers. So I'm going to look to our committee members first, and then actually second to invite task force members and then members of the general audience. I'd actually like to just start off by addressing a question to Amy, which is this. I thought it was really intriguing that the Community Preventive Services Task Force seems to try to signal researchers and funders directly through giving statements. And I think you said, you can use it as a section in the background of your grant application. Can you tell us a little bit more about how the Community Preventive Services Task Force may use any kind of taxonomy? Do you use PICO's, the population intervention comparison outcome setting taxonomy similar to the U.S. Preventive Services Task Force, or are there concepts that your task force tries to define in communicating with funders and with researchers?
Thanks for that question. I would say there's not a taxonomy per se, but I think we do tend to focus evidence gaps around applicability factors, and those have to do with the population, with the intervention, and with the setting. So we're not sort of specifically tagging it to PICO, but we are looking at those factors to identify what some of the evidence gaps are.
That is great. And actually, I'm going to look at the participant list, and just to signal the committee members, if you're interested in asking a question or making a comment, go ahead and put your hand up in the Zoom participant list. If you are not able to raise your hand in Zoom, then you can put your video on and wave, and we'll see you. So I actually see Venkat, and then Anne after Venkat.
Yeah, hi, thank you. I enjoyed the 4 presentations. Thank you all very much. So I have 3 specific questions, but before I get to them, first I want to bring to everybody's attention a recent report released by the National Academies titled Endless Frontiers, the Next 75 Years of Science. The report goes through the history of the last 75 years, starting from the Vanover recommendation of funding individual investigators in academia, and the successes of it, and then concludes that we are probably reaching the limits of that model of celebrating only the individual investigator and those kind of sciences, which is going to be important. But in the future, we might require a lot more larger team, interdisciplinary science, and greater collaboration across different funders to solve the contemporary problems of the next 75 years. And I'm wondering whether a lot of the constraints we are finding with advancing clinical preventive services or community preventive services fall into that category. And as I was thinking of many of the limitations that Mike addressed, to me, many of them were not limitations. It was because we are trying to drive, round pegs into square holes or the other way around. I think that may be the problem. So let me give you 3 specific questions from the presentations. Firstly, we heard the community preventive services, and we hear the clinical preventive services. I would argue that the 2 need to get more integrated. because the very fact that we keep them as silos, it creates a lot of duplication and unnecessary contradictions. So why can't there be greater collaboration between evidence assessment for clinical preventive task force and community and preventive task force and its implementation, number one. And secondly, Mike mentioned the pragmatic trial of GDM screening, which I enjoyed reading in the New England Journal of Medicine. Why not more of those models? Why can't there be trans NIH standing RO1 RFAs to address those kinds of questions through pragmatic designs, through larger RO1s? So if that sort of a mechanism was available, which was cross-cutting across NIH institutes, which enabled more of pragmatic trials, I would argue that the cost of trials would go down substantially. And thirdly, going back to this report, Endless Frontiers, they argue that we need a lot more international collaboration. So why not bring that principle of greater international collaboration? It would make faster design, faster recruitment, lowering of the cost, and more generalizability.
This seems to be a question in part for Mike. And so I think that your focus on randomized trials was very intriguing. Of course, the task force loves trials, and researchers like trials if they can be funded appropriately. What do you see as the future for some of these areas in which an I statement would require a very large trial? Do you think that we will see more large trials, or more of a push to get pragmatic trials, or what does that future look like?
So Venkat's points are absolutely spot on, and I'm looking forward to reading that report. I do think so. Several thoughts. One is that large-scale networks definitely have a role. Part of the reason why why COVID was successful, while they were able to do the trials both here and in the UK, is because the networks and the infrastructure already existed. The second issue about pragmatic trials, this is something we've been talking about for a long time. NIH funded a Common Fund initiative about 10 years ago called the Collaboratory to do two things. One was to fund a series of pragmatic trials, which has been done. And the second was to develop an experience, a learning experience about how to do pragmatic trials. One of their outputs has been what's called a living textbook of pragmatic trials. And we have funded a number of pragmatic trials, including the one that we just mentioned that came out last week. I think that with large-scale healthcare systems becoming more the norm, networks like PCORNet, which potentially have a tremendous amount of power, these kinds of leverage trials, registry trials, or platform trials are more likely going to be possible, feasible at lower cost than what we're seeing right now.
Okay, let's thank you, Mike. Let's look to Anne, who I know has been waiting to ask a question.
Yeah, thanks everyone. Really stimulating presentations this morning. Sparked a lot of thoughts and questions. Just a question for Hal. I appreciated your point about research priorities and gaps come not just from the literature, but from the end users. And how are you, can you give a little more detailed thoughts about how to solicit that and how to do that in a systematic way? And then I would ask David, in terms of the frontiers of EHR, big data utilization, pros and cons of pushing that methodology forward.
Well, great question. I think if I were calling the shots and we were interested in doing a study on a topic, I'd probably, one of the elements of the planning would be to go out and do a very high quality survey of the target audience, be it patients or clinicians, and really try to get down deep and perhaps find some of those evidence gaps that never find their way into a systematic review. So it's a great question. Thank you.
Great, and I think the other part of that question was for David.
Yeah, and let me just first build on the question of pragmatic trials. I mean, I do think that's something we're interested in. I mean, the real cost savings in a pragmatic trial comes when you can rely on routinely collected outcomes. You know, so our confirmed trial would be considered a pragmatic trial in the sense that we are not individually following 50,000 patients to survey them and to we are relying on the health system to detect whether they got cancer and whether they died of cancer. And so it's still an expensive trial, but it's much less expensive than if we were drawing annual blood specimens or subjecting everybody to a follow-up colonoscopy at the end of the trial to see whether they had polyps or cancer. I think your question, Anne, was about, you know, the limits of EHR. So I do think, you know, drawing strong evidence from observational data, it was a challenge in the days I was with the task force, and I don't know that it's gotten any less of a challenge. I mean, I think it depends. There are a couple of ways I think you can use EHR data. The one that's probably the most challenging is if you are looking at a sort of before-after effect of putting in some new screening process into place or some new intervention. We actually tried, we have been trying when the VA rolls out new programs to randomize that rollout of the programs to try to bring more rigor to it. And what we found was, and we tried to do that with the suicide screening and intervention. So the secretary was interested in rolling out, we have a computerized risk score to identify the people at highest risk of suicide, and we were going to do proactive outreach to the top 0.1%. And we thought, well, we're rolling this out nationally. It'd be great if we could randomize rolling it out to the first set of sites and then 6 months later to the next set of sites, and we could do a step wedge design. The problem is with a big organization, especially one that's sort of political like the VA, is it's very hard once people want to do something to get them to conform to an ideal design. And it's really hard to get to that level, to find something where there's equipoise, where people are interested enough that they want to do it, but dispassionate enough that they'll wait 6 months. And you find you get people really passionate and they don't want to wait at all and they're going to start. So I would love to have a world where all our new things were, I think Ian Chalmers was the one, you know, randomized the first patient. And it's just been challenging. You know, how much we can learn from natural variation across 1,000 sites to find, you know, do we see differences in places that are at 70% use of some intervention versus 40%? You know, I think those are rarely going to by themselves going to resolve an issue, but they can be informative. So I'll let other people kind of weigh in. I do think sometimes, as I tried to point out in my slides, you know, the question is not so much does early detection work, but, you know, what about a population that hasn't really been studied and low risk? So if you take women with AAA, right? So we're probably not going to do a trial of EVAR versus watchful waiting in women with aneurysms, but we might be able to follow a cohort of women who would sort of reflect screen-detected aneurysms, you know, and then just follow what's happened to them and try to get a sense of, does the biology, can we really extrapolate reasonably from men to women, and we can better quantitate the adverse effects, you know, so sometimes it's, well, we think the harms are going to be higher, but the more data you have, the more you can maybe be comfortable making extrapolations from one population to another.
That's great. Thank you so much. Great observations. We have just a few more minutes, and I saw Wanda raise her hand. I saw that Ted had his hand up, but let's go to Wanda first. And Ted, just depending, we'll either go to you last or take our break. So Wanda.
Yeah, I'm trying to figure out whether what I have to say is a question or a comment. But first, let me say that I enjoyed all three presentations. Thank you very much. And as an obstetrician, I was delighted to see the pragmatic trial on GDM screening in the New England Journal. So that was great to see. I guess my question is, sort of thinking back over my task force experience, I don't know that we were thinking as much about pragmatic trials at the time, and certainly they have become much more popular and used more often now versus 5 or 6 years ago when I was rotating off the task force. But I guess I'm wondering, should we think about how we then incorporate that option either into the prioritization of the topics? Could that play a role in how feasible we thought evidence could be obtained, or somehow in the taxonomy? And I'm not sure. I'm sort of thinking out loud as I'm talking, but as I was listening to the presentations, I was thinking this is another great option, a pragmatic trial, just in terms of the trial design. As part of what we also need to do, our part B, is to figure out where it could be integrated into the task force thinking process, and perhaps further upstream in the prioritization phase. So not sure if that's a question or a comment, but I'm interested in some responses. Yeah.
Tracy, really quick. I think Wanda's comment is absolutely spot on, and that should be part of the taxonomy. Is how much will it cost to answer this question? How feasible will it be to answer this question? And is it possible to answer this question in a novel, innovative way that potentially will be faster and less expensive?
Well, great question and crisp answer. So thank you for the perspective. Good, this is very, very helpful. Ted, would you like to pose the last question or comment?
No, given the time, I think we can skip my question.
Okay, well, thank you for deferring. We'll go ahead and go on a 5-minute break. Alexis can watch for us. I see that it's 9:13 Oakland, California time, which means it's 12:13 for those of you on the East Coast. And why don't we plan to come back at 20 after the hour? That way we have a 7-minute break, and we'll see you then. Thanks.